So the role of transplantation in MPNs is limited to patients with myelofibrosis or patients with accelerated or blastic phase disease. Unfortunately, many of our patients are not really eligible for transplant, even though it is a curative treatment. It's also an extremely risky one, and so it's really important that we think about that interface as to when that might be an important and useful strategy, an appropriate strategy in fact, and when not. So just thinking purely about myelofibrosis, this is getting complicated now because we've got combination approaches trying to improve our frontline and second line responses. We've got 4 different JAK inhibitors. So still the thinking is, yes, there is a role. And yes, for a patient where you're thinking that transplant is going to be a preferred mode of therapy, you should take your patient to transplant at the time when they have their best response to the JAK inhibitor. That is a tough message to give to a patient, but the evidence suggests that is the case. Rather than cycling patients through repeated therapies, it's really definitely the case. In accelerated and blastic phase, ideally, of course, we want to be offering the patients a curative therapy if we can, although our chances of cure are less in that context, and we would definitely, again, wanting to be moved towards a transplant after some debulking therapy while the patient is in accelerated rather than at blastic phase.